Thank you. Really interesting session. I am really jealous because in my trust we don't have a sepsis nurse. That kind of falls under my remit. We have the outreach team. So just to clarify, you are a separate team to the outreach team.
So I own both of them, and they were all based as outreach nurses. And then we developed the sepsis team. We all started together and developed it together. So they do cross cover, so they will do outreach as well. But then our band 7s primarily do, well, we don't, the 6s don't do sepsis. So you do cover some outreach still, don't you?
Yeah, so on a day shift we'll have a sepsis nurse and an outreach nurse. It's okay.
And it is a really nice thing because you do find that most of the patients at outreach see are septic. You know, that's the nature of ITU patients. And so, you know, if they refer to somebody with ITU skills and they do the treatment and the lactate clearance doesn't happen and they look like they're going to need vasopressors, we're in a good situation. We know our ITU doctors, so it's a nice place to be, to own it.
And A&E is not in your remit, because I know in my trust 87% of our septic patients are in A&E.
They are, yeah, and that's the same with us, yes. So our old consultant lead was A&E, so she tended to do a lot of the work in A&E. They do their own auditing and they've got quite a robust plan there. It was the hospital that was the problem. So we still, I think we have about 40% opened in our inpatient areas, and those were the ones that just weren't getting closed and weren't getting looked at.
I'd like to thank you ladies coming today and telling us what you do. It's absolutely amazing. I've got my own personal experience. I had sepsis in 2014. I was on the ward. Went in with pancreatitis, and I was there for 2 weeks, and then my consultant came on the ward. It was Christmas. Came on the ward. I knew something wasn't quite right with me, and anyway, they came on the ward, and he says, "You need to check her early warning scores." I was scoring a 10. Anyway, it was contained on the ward, which was really good. I didn't go on to ICU. But what you've done for your trust is amazing. I'd just like to thank all your what you've just said to us today. That's absolutely fantastic.
Thank you. Thank you.
So in terms of the patients that you see then, do you see any differences in the types of patients that either get closed or don't get closed? Or, you know, in your data, are you able to separate out your different demographics of your patients, or is it just a mishmash of everything?
It's a mismatch. Yeah, it's a mismatch. We see a very different set of patients from outreach to sepsis because we've got completely different end goals. So with your outreach, you can't see everybody that scores a 5. So you'd be saying a 7 or a new concern, high oxygen requirements, because you haven't got the same end goal. With sepsis, it's very much the case. Somebody could be palliative, but you could get that person home. You know, so you can make a massive difference with changing that patient's journey. So it's just a very different sort of patient that we do see for sepsis.
Cool, thank you. Okay, I think, yep.
Hi, I'm Sarah from Leicester. It's a data question again. You say your vital packs will identify your trigger for sepsis. At what point is it pulling through the IV antibiotics? Is that reliant on an individual putting a time in?
Yeah.
And how can you be sure that that time is correct? Do you ever validate that time, or do you take that as read?
Well, this actually happened at the start of the trust, so at the start of the service, because there was a director in A&E that called me and said, I want to know why our figures are loads better. She says, and I've pulled all these patients' notes to see you actually, your names are on it, your names are on them a lot, and they actually add everything. And she went, and they have, so what are you doing? And we're saying it's an absolute laborious thing to, to go back and to fill it and to back time it all. But yes, we have got assurance that because we're not going to.
So when we pull the reports, we visit the patients the day after. We'll go and look at drug charts and we'll time them. We look when the antibiotics were given. We'll look when they were clerked, when they're post-taken. We go through everything. We make sure the patient's still not scoring, if they need any active treatment there and then we can backdate them in retrospect and close them on vitals. But we have to physically go and visit the patients. That's why it's nice being patient-facing as well with the team we do.
Thank you. And one last thing, good luck with vitals.
Honest.
I'm nerve centre and I'm still waiting.
Yeah, I don't think it's going to be anytime soon, the new guidelines.
I think they're just fib to keep us quiet, but nurses don't stop, do we?
Did you say only 20% of antibiotics were appropriate?
So,
Or did I mishear that?
no, that was right. So we were giving blanket tazocin to people.
Oh, I see, okay.
So that would be your first, you
Dose.
know, on your drug charts where you have your first initial stat dose. It was never going to be tailored to a patient. It was always going to be, have they got a penicillin allergy, haven't they? And then they give it. And so with Aidan, who was our lead microbiologist, we worked really hard at sort of looking what was the actual diagnosis, what was the news score, did it improve, didn't it improve, what happened to the white cell CRP. And then he went back and challenged people. So then they started using microguide
Okay,
and then sort of actually giving the right antibiotics for the diagnosis.
nice.
Which
well
has just
done.
been revamped as well now, hasn't it?
Yeah.
The trust, yeah.
And what happens at 48 hours? So we've got, do people know about Start Smart Then Focus? Oh, I love it, thank you. So Start Smart Then Focus, because this is the balance with sepsis and stewardship, right? Is people worry about too many antibiotics. And I went to ESCMID, which is our European Clinical Infectious Diseases Conference, and one of the things I learned from that is moral injury. And I was like, what does that mean? And it's the guilt that we give healthcare workers, that we give ourselves, we give patients, because we're in this journey of we want to use less antibiotics, or the potential. And we do want to use less antibiotics because we want to make sure they're there. But I guess with sepsis, there's a bigger moral injury, right? Because people are scared that if they miss it and something happens, that we're going to have it in the news. Like that, you're going to be that person on the news. So the point then is about Start Smart Then Focus is if you think you suspect, to give that first dose. But my concern is what happens at 48 to 7, because 48 hours is then focus. And is that happening in your trust? And how do you manage that happens?
That's a difficult one, isn't it, really? So we would only be able to pick that up really on referrals and by looking at news. So we check the news every year on patients that are triggering. So if somebody had fallen off a perch, we'd find them that way. But that would be relying on referrals really, wouldn't it? Which it is a bit of an issue. But no, I find it's more sort of de-escalation's the problem in hospitals, especially they'll say, but Tazocin's better. I want to give Tazocin because that's a better one, or I want to give Meropenem because that's a better one. Why wouldn't you? There's a real, they don't like to move down to oral antibiotics. You know, IV's better, and patients themselves, they want antibiotics, are in hospital, they don't want to just sit and have oral doxy. They want the Tazocin as well. So I think that's
Yeah, so the focus, so Start Smart Then Focus is, give the appropriate one. If it's sepsis, give it with now, all that. And then the focus is you can either de-escalate in 48 hours, is reduce, change it to that. Now, it could be broader spectrum as well. Make sure if you've got your data back. It could be IV to oral switch. It could be OPAT. And there are 5 decisions that we recommend within the Start Smart Then Focus approach. But I guess back to the audience then, has anyone cracked this focus part? So 48 hours, they've given the antibiotic, they've gone to Tazocin, or we have a pet name for it. But then what happens over that 48 hours?
Cheers, thank you. Yeah, Dan from Nottingham. Just in response to that really, at Nottingham we have antibiotic champions. So these are medical professionals on every sort of specialty ward area. And once a quarter, they produce a relatively in-depth audit, actually, of a significant number of prescriptions for a proportion of the patients on the ward. So essentially any patient who is on active treatment with antimicrobials will be part of that audit process. And so we have an ability, therefore, to understand what happens following prescription, initial prescription, and we can then learn from that and provide feedback to our colleagues. So perhaps that is an approach that could be mirrored in other places if that is considered to be helpful.
And I think it's worth bringing that up because if you go, I think, as you said, people were thinking you were infection prevention and control, so they're running away from you. But I bet some people are also thinking, oh, they don't want me, they want me to give more antibiotics. So if you, the steward will be like, oh, I don't want to, I told the AMR, and, you know. But I think the point is if we can really help people to see that there is that focus part, 48 to 72 hours, or even 24 hours, review the patient and make a decision. But before all of that happens, they have to write the indication, right? So this is why we've been on a journey in England, and I've been doing this role since 2010. So I've been here for a while. And I remember when I started is documenting indication was not done. And so part of what we brought in through Start Smart Then Focus was that part of why you get sequenced sometimes is to encourage these things to happen. So we apologize for it, but hopefully in your roles, you can see the benefit of why some of these national interventions are put in place.
Thank you so much for your talk, all of you. I think your approach and your perspective is really innovative and inspiring, and there's a lot of nuggets in that presentation that I thought was just really golden and really positive. So, thank you so much for that. I did have a lot of questions, actually. A lot of them have been asked already. One thing I suppose I'm interested in, just based on, I think you briefly mentioned it, and it just got me thinking, which was you said that you tend to kind of segregate your Band 7 team to look at and go to treat the sepsis patients. And I suppose I'm just intrigued to understand how you know what is a sepsis patient before you go and review them, if that makes sense. Because at the point in time that they're just a deteriorating patient, we're not always sure if it's sepsis at that point.
Yeah, it's really difficult. I think sometimes you'll end up for a couple of hours with a patient in AF, won't you? Yeah. Or heart failure, and it won't be sepsis. But
okay.
Because we're outreach background as well, if a patient needs you, a patient needs you. So I think sometimes you'll go on what the nurses have done, they'll have done the trigger, and it won't always be a true sepsis at all. So there'll be various reasons why they will be triggering.
Oh, so it's kind of based on the sepsis screening more. Yeah. So got you. Right, yeah. Okay, fab. And then as a follow-up to that, sorry.
No, it's great.
I can't stop talking.
Still got time.
As a follow-up to that, I think I'm intrigued to just know your perspective on the fact that one of my worries, I think, being in the position that you're in, which is really fantastic, you've got this established sepsis team, but as a bit of a double-edged sword, I suppose, I might worry a little bit about maybe the sort of de-skilling of the healthcare professionals on the ward areas who might tend to then perhaps assume that sepsis patients, that's not our responsibility, the sepsis team will come and sort out the sepsis patients. And have you ever seen any evidence of that? Or is that something that you're
I have seen ward rounds where they've come back after 3 hours, but then rather than just to take that, we're going to own that, we joined the gram round instead and said, no, this can't happen. So challenging it there and then to say, okay, if you see it and you can't do it, do call us, but you need to actually do something. So we can't take ownership for these patients because they're not all going to go to our ITU. They have to sit under the medics still.
And sometimes they get in touch when they're difficult to access, don't they? Or difficult to get lines in, and they think that we can do it, but
we're an access team.
You're an access team.
Thank you so much.
Thank you for that. There's a question at the back. While you're on your way there, you mentioned 1 hour and 3 hours, and that you sounded like you were feeling a bit guilty because you're not doing the 3 hours. I have heard other people here say that they haven't necessarily moved to the 3 hour new guidance because they're worried that their 1 hour in the first instance, they haven't actually got that right. And there are patients who wait till 3 hours in the first instance. So if you then go to this 3 hour opportunity, then actually it could be 6 hours, and then we know that patients are really going to be harmed. So I guess if people are in the room, if you wanted to say, as anyone, maybe I'll go, who here has moved to the new 3 hour approach? There's three, 3 organizations. So what I'm hearing is that you're not an outlier.
Oh, okay. Okay, that's good. I know that I think Wolverhampton have moved to it in A&E, but it was quite hard to understand because I don't know if they're taking lactates into account, and the lactate's the most important thing really with the news. So it's just a bit hard while you haven't got a measurable way of doing it.
Yeah. And those who have, so I spotted your hand and someone over there. How is it going for you? Sorry, actually, Alan, there's someone over there who said they have. So maybe you start at the back and then come to the front. Sorry, we'll come back to your question.
Hi, Sian from Dudley. We adopted the new guidelines. We made a change when we were making some digital changes. So we went across to the AMROC guidance within a month of it coming out because it just fitted with where we were making digital changes. So our IT and dashboards actually look at what we've achieved within the hour and what we've achieved within the 3 hours. So we have that segregation and we have the IT to support it. It was just pure luck on timing, because if we hadn't been making changes at that point, we'd probably still be waiting for IT changes now. We found when we do education, particularly to medics, I still emphasise the hour and make the point, like Ron did earlier, that actually what are you going to benefit from waiting on your prescribing decision? And for a lot of people, the only thing they might hear back is a scan. So if you're waiting for a scan, by all means, wait and then make your prescribing decision. We've got some safety netting on our dashboards that if it's a 3-hour decision, the dashboard changes and it has a different colour. It has a little orange for the amber and it says antibiotics, so it shows that the decision is still outstanding and then disappears once that decision's gone. So you've still got visual prompts on the ward on the dashboard for the 3-hour people, whereas the sepsis 6 will have an S and a 6 if you're on the hour, first of all. So we've put safety netting in within it. Strangely enough, we hit the 3-hour really easily because most people are still aiming for an hour.
Okay, interesting. So, thank you. If we ask, go for the question at the back there, and then please we'll want to hear from you as well.
I'm Sarah from Kettering. It sounds like you mainly cover adults. Is there any sort of service like this within your trust that covers children?
So we're not a secondary centre, we're quite a small paediatric area, and we've got good relationships with paediatrics, and they actually do a really good job themselves, don't they? So
Especially A&O.
Yeah, so their compliance is a lot better than the adults. So they're really proactive. We're just moving into paediatrics at the moment with Martha's Raw, but we don't go and see as a sepsis, but we've got assurance from them that they are really good actually at doing it, aren't they? So no, we don't do paediatrics, and we're already stressed about the Martha's Raw bit.
Might push us over the edge.
No, that's great, thank you.
Something I'm hearing, we talked earlier around research, but something I'm hearing, there's a lot of work is done around audits, around quality improvement. And whilst that's not pure research, it is a part of research. So if you're getting involved in audits and quality improvement, you're on your way to research. And actually, if you build in research methodology into what you do, you are doing research. Just thought I'd plug that in there. Alan, if we can come to the front here, and then I'll take one more question, if anyone's got any question. And ladies, if you've got any final tips or any final information you want to share, then you can do that. Cheers.
Hello again. So I'm Mike from the QE Hospital in Kings Lynn. So when NICE released their new guidance, we took on the new UK Sepsis Trust sepsis tool. We're very much paper-driven at our hospital at the moment. A&E has a very basic EDIS system. So we are struggling. Essentially, I meet all the nurses and doctors on induction, and I teach them a bit about sepsis. I share the new sepsis guidance. On audit, I would love to say we're doing much better than we are. Certainly with antibiotics, we're not too bad. I would say 86 to 90% of septic patients get their antibiotics within the hour. And also on audit, and the way we've set up our Excel spreadsheet is if there's a justified reason for not giving the antibiotics within the hour, we document it. And we do have a very small number of cases, and your classic example is a patient with shortness of breath, mild cough, low-grade pyrexia, chest sounds clear, scoring a 4 or 5 on the new scoring system, and you've got a couple of hours to do your CRP, maybe get a PCT if ITU get involved, do a chest x-ray, and you can kind of say, oh, it's a PE rather than a chest infection. So we haven't got massive numbers to say it's working, but I think we do get a small number where we are following NICE guidance. But as a general rule, as a trust, I'm ashamed to say we have a long way to go in doing the full sepsis 6 within the hour.
Hi, I'm Marianne from Outreach at Derby. I just wanted to ask, you mentioned that you have a rehab service. Is that for post-critical illness or specific to sepsis, and what does that service look like?
So it's for post-critical care, so post-ITU. So anybody that's been within ITU for 72 hours, and then we follow them up. But the service has just been depleted due to funding. So it was quite a robust service, wasn't it, prior to that?
We were really responsive to our post-COVID patients. And so you had a really strong team, didn't you?
Yeah, there was two. We had a band 6, a band 7, and also a physiotherapist that used to see the patients. And we used to do every patient was followed up on the ward, diaries, prescriptions. Everyone had clinic appointments, post-ITU diaries. But obviously that service has just been reduced quite significantly, unfortunately, just because of funding.
So we're looking at what that will mean. So they want it more into ITU, so I think I'm going to give it to them and I'll take acute pain instead. So,
but if you need anything with rehabilitation, just get in touch with me. I'm happy to answer anything.
We follow up all the patients from ICU, especially the ones that have been intubated for a certain amount of time, to have that post-psychological discussion. But it's obviously we're not trained psychologists, so that doesn't go on for an extended period of time. But it's more of a follow-up and a chat, and then information about ICU clinic follow-up.
See, I'm also a qualified counsellor because they put me through 3 years training. So I was three years trained, so I'm BACP accredited counsellor to capture those until they can get to a psychologist. Yeah.